refractive errors and a little bit theory of retinoscope. Before going into the refractive errors and retinoscopy, let me explain you different types of refractive errors. The normal state in which there is no refractive error, when a patient is can read the lowest most line at 6 meters or 20 feet with one eye closed, then we call him that he is having a vision of 6 by 6. Then we close that other eye and the other eye is checked and the vision is noted. If the vision in both eyes is 6 by 6, then we call it a state of emetropia from E, that is no refractive error. If the vision is decreased, for example, he can read only 3 or 4 lines, then it is called ametropia. Now, ametropia means there is some refractive error. There are three types of main refractive errors. Number one, myopia or nearsightedness, in which the rays of light are formed or image is formed in front of the retina. Second refractive error is hypermetropia, in which the rays of light are focused behind the retina. Third is the astigmatism. In astigmatism, single pointed image is not formed and two images are formed on the retina. So, when we come across a decrease in the vision, then the first step which is important is that by occluding one eye, we place a pinhole in front of the eye in which the vision is decreased. For example, a patient can see 4 lines. It means his vision is 6 by 18. What does it mean? It means that a normal person can see this letter from 18 meters, which he is seeing from only 6 meters. So we will place a pinhole, which is a very important and very simple test. The important thing to remember is that pinhole differentiates between the refractive errors or the decrease in the vision because of some other cause, because like cataract, corneal opacity, uveitis, some retinal issue. So if the vision is improved by pinhole, it confirms that the patient is having some refractive error. It doesn't tell us what is the type of the refractive error. So as our today's topic is refractive error, so we suppose that after placing the pinhole, his vision comes from 618 to 6 by 6. Now the next step is we will have to measure the refractive error. For measuring the refractive error, we use conventionally this instrument which is called the retinoscope. And in exam, you people or sometimes it asks to recognize this instrument. Don't confuse it with ophthalmoscope. Moreover, don't be misunderstood by its name. It is called retinoscope, which literally means that to see the retina, but actually it is a misnomer. We cannot see the retina with retinoscope. It is used to measure the refractive error. The retina is seen by ophthalmoscope, and the refined form of
सारे ये पेशेंट पेंडिंग में दिखाते हैं तो ये सारी लेटर
Pause.
होता है
मेरे लिए काम लंबा हो गया. चलें, let's start. So this is the retinoscope, and it is used to measure the refractive error. The refined form or you can say the latest technology uh, which has almost replaced its retroscope is auto-refractometer, where we place the chin of the patient on the chin rest and it automatically gives the reading. But there is no substitute of retroscope. The refractive error which we measure with the retroscope is still its readings are more accurate than the auto. So, or for example, if I focus it, you can see a streak. And what we do, I will tell you only briefly, as today we are not going to discuss spectroscopy in detail. This is the patient's eye, and I will, from arm's length or 2/3 of the meter, I will move this spectroscope like this along the x-axis. That is, we check it in two meridians. When I will move it like this, I am checking the x-axis, right? And then the image of the retina is is we see it like this, okay? And we move it, and the image through the pupil of the retina is formed, which moves. In normal patient, it moves with the retinoscope. We call it with movement. Like I move the retinoscope right, the image will of the retina will also move towards the right side. Are you getting my point? Now, if the patient is hypermetropic, that is, if he has got, for example, +2 or +3, again it will move with the movement of the retinoscope. Then we check it in the vertical meridian also. And if it is myopic, then it will move against the movement of the retinoscope. That is, the retinoscope will move, for example, from left side to right side. The image will move on the opposite direction. Understood? Similarly, if I BD check on the vertical plane, the light will go up, the image will go down. These are the very basics of vectorscope. Now, in our next session, where we will be discussing in detail which lenses are used in against movement and which lens is used in with movement, in that we will discuss it in detail. Today it was just an introduction of the retinoscope. मैं अभी क्लास ले रहा हूँ बाद में जरा now we will discuss the refractive errors. So as I told you, there are three types of refractive errors, and one is myopia or nearsightedness. What happens in myopia? This is the retina. You can stop me there and then where you have any questions, or if you feel something you are not able to understand. This is the retina and this is the cornea. I am making a schematic diagram. The rays of light coming from the cornea, they form the image somewhat here. Okay? Image is always formed inverted. So it is a high myopia which I have made so in front of the retina. Usually depends upon the, for example, this this one. So this is the image being formed. Now we have to replace this image on the retina. so that the patient can see clearly. It is myopia or nearsightedness. As the image is formed in front of the retina, so the patient will be able to see the near things more clearly as compared to the far. So it is also called nearsightedness. Now there are three options of this treatment. One is that we will, in front of the cornea, we will place the concave lens in the form of glasses. We will measure the refractive error by arthroscope or autorefractometer. For example, it is -3 diopter spherical. We will place a -3 diopter spherical. It will, what one thing is very important, that we check from 6 meter, because the rays of light are parallel from 6 meters or more than 6 meters. When the light is coming from 6 meters or from more than 6 meters, we suppose that it is coming from infinity, right? So it is parallel. At 5 meter, it is not coming from infinity. So the standard is at least the distance should be 6 meter or 20 feet. So the parallel rays of light pass through the divergent lens and it diverges the lights. Getting my point? When it diverges, ultimately it will form the image on the retina. समझ आ रही? ठीक है? Now this we have calculated this refractive error with the help of refractoscope or autorefractometer. This inverted image is perceived in the brain as through learning, that brain makes this image upside down and laterally inverse. That is, it makes us see the actual object. The on the retina, the image is made upside down, and brain sets it into the right position in the visual cortex. Got it? Now this is myopia. The other options of treatment for myopia are, again, our main aim is to bring this point to here. One option, which is the most common and most recommended, is glasses. Second option is that in front of the cornea we give the contact lenses. Okay, daily wear contact lenses, extended wear contact lenses, which but they have their own advantages. That is, you don't need to have wear the glasses if you don't want to wear the glasses, and it has its own disadvantages, that after all it is a foreign body in the eye, so it can cause irritation, or most severely it can cause corneal ulcer. So this is the second option, that is contact lenses. Third option is, if a patient is young, that is above 18 and below 40 usually, but at any age it can be done, is the refractive surgery, in which we change the curvature of the cornea, because we cannot change the axial length or anything else. The only control we have is on the cornea. So in myopia, what happens? Patient's cornea is like this. Then by laser, what we do? We do laser and make cornea flatter, so that its refractive power is decreased. Now, what are the procedures of refractive surgery which are usually in practice? I used to perform LASIK, laser in situ keratomaliosis, in which what we do, this is the cornea with a special microkeratome on a very highly sophisticated machine. We cut the flap and make the flap and lift it, and it is lifted, but it is still attached at the hinge. We do not totally remove it, and at the base of this flap on the stoma, uh, we or the we apply the laser. The laser which is used in LASIK is uh, examer laser. There are different types of lasers which are used in ophthalmology. Examer laser is used how and how much of laser and at which meridian if it has to be done. These are all the calculations which we do before the laser refractive surgery. We plan it, we do corneal scan, corneal topography to see any disease like early keratoconus, in which any site or any type of refractive surgery is totally contraindicated. Any other corneal disease, if everything is fine, then we go for it, and by microkeratome we make the flap. We apply the with the foot pedal the laser. It's a less than 10 minutes procedure. After doing that, we replace the flap, and the patient becomes immediately fine after the procedure. And the second procedure is after LASIK is the trans PRK. It is a relatively older procedure, but the results are equally good. In this procedure, we do not lift the flap. What we do, this is the cornea, this is the cornea, and we directly apply the laser over the cornea. And by the technology, it flattens the cornea. But as we apply the laser, it disrupts the epithelium and the anterior stroma. So, in the LASIK, the flap was not, the upper flap was not manipulated. So, when it was replaced, the patient does not feel any sort of discomfort. But here, when we have applied direct laser, patient will experience little pain, discomfort. So we apply a bandage contact lens over the eye for about 1 week, so that the epithelium and stroma is healed, and we give the medicines, steroids, antibiotic combination, and anti-inflammatory in both the elastic and trans PRK. And third one in the refractive surgery is the PRK. PRK is the earliest of its type of these latest procedures. There are some other which have gone now obsolete. In PRK, what we do, uh, this is the cornea, and with the special spatula, we make a. This is cornea, this is pupil, and this is a special instrument. We make apply this instrument here, and we apply a pressure, and then with a knife we remove the epithelium from this area, right? So now this has come, this is a pupil, and this is the area of removed epithelium. In trans epithelium, the laser removed the epithelium. In PRK, we manually remove the epithelium. Okay, and after that, we apply the same examer laser and then place the bandage contact lens. It has a little longer convalescence time of discomfort, slight pain, blurring, but the end results of all the three procedures are almost equally good. but LASIK is very expensive as compared to these two procedures. Now let's come to the second refractive. अभी तक समझ आ गया? कोई question? ठीक है?
Yes, sir.
Now we move to the second refractive error, which is hypermetropia. In hypermetropia, the rays of light are formed where?
Back of the retina.
Behind the retina. So, what are the options of correction? We have to bring this image over here. So we will place a convex lens in front of the cornea to increase its power. समझ आ गई ना? And after calculating it with retinoscope or auto factor, for example, it is +3. Then it will become on the retina after further it has further converged. Okay. Second option of the treatment of hypermetropia is again the contact lenses. Okay, but the refractive surgery is usually mostly not done in hypermetropia because technically it is difficult to make cornea more steeper, because in myopia cornea is more steeper and we make it flatter with the help of laser. But to make the already flatter cornea in hypermetropia, to make it conical steeper, we will have to do the laser in the periphery. So its results are not very good. So mostly it is not done. And refractive surgery is confined mostly to the myopia and astigmatism only. And astigmatism also, if it is myopic astigmatism. When we will shortly be discussing the astigmatism, you will come to know its different types. So the last refractive error is the astigmatism. What happens in astigmatism? One image is formed here and the second image is formed here. Okay? Now it can also be, to understand, we can do this, that two images are formed, both images are being formed behind the retina. Now forget about for a second that it is astigmatism. If it is not astigmatism, then what type of refractive error is this? Hypermetropia. So if both the rays of light are formed, I am going to make 5 diagrams like this. If you will listen to it mindfully, then you will be able to understand astigmatism very easily. So it is hypermetropia. One thing is confirmed. Now both rays are formed behind the retina. So it is called compound hypermetropic astigmatism. What would be the second option? Now आप खुद बताएंगे. One is that one image is still formed behind the retina and the other image is formed on the retina. It is called simple hypermetropic astigmatism. Understood? Then third stage is the normal state in which both rays are formed on the retina. It is emetropia, no refractive error. Now, what is the other option? One ray is being formed on the retina, the other in front of the retina. What will you call it?
Simple myopic.
Yes, simple myopic astigmatism. And what is the other option? Where should I draw the both lines? Where should I draw the both lines?
In front of it.
Yes, both lines are formed in front of the retina. And you will call it compound myopic astigmatism. Understood? So these are the 4 types of astigmatism. And the treatment of astigmatism depends on the number. The myopia is treated by spherical lenses of minus power which diverge the rays light. The hypermetropia is treated by convex lenses which converge the rays of light coming from 6 meters. In astigmatism, it depends. We use both the spherical lenses and the cylindrical lenses. Understood? That is, for example, the patient's number in the previous examples was -3 diopter spherical. In astigmatism, it will come this and -1 diopter cylinder at 180, for example. It will tell you that you will have to give -3 diopter of spherical lens. It is compound myopic astigmatism, and you will give the glasses like this. This is the eye, and this is plus 3 -3 diopter spherical, and another lens is placed over here whose axis is at 180 degree and power is -1. And remember one thing, that cylindrical lenses always act perpendicular to their axis or 90 degree to their axis. That is, at the we are giving the lens at 180 degree, the power which it is giving at the 180 is 0. Its power is -1, power is actually in the 90 degree. Understood? Because they are made in a way that in one axis they have 0 power and in the other axis they only have the power. And as we need the power only in one meridian, so we have to use cylindrical lenses, because if we give the -1 of spherical, then it will overcorrect this -3 diopter spherical. Therefore, a lens is needed which has power in one meridian only and other meridian has 0 power. Understood? So that the cases of astigmatism can be taken care of. Now, if this is hypermetropia, only the sign will change, and it will also depend upon whatever the degrees coming on the rectoscope or refractometer. So, whether it is myopic astigmatism or hypermetropic astigmatism, we will have to give a combination of spherical and cylindrical lenses. In some cases, spherical number is usually negligible, or patient does not have any spherical error. He only has a cylindrical number. That is, he needs either minus or plus number at specific angle. For example, 90 degree or 135 or 180. When you will place the lens and you will move every 5 degree, then he will say when his axis will be approached at the right axis, he will say yes, it is clear. If you will move it clockwise or anti-clockwise, even the displacement of 5 degree will cause the distortion and doubling of the letters. So cylindrical lenses have to be given very carefully. So this was our small talk about basics of refractive errors. One thing I want to clarify in the end, that presbyopia is not a refractive error. Many students, maybe it is written in some books, do this mistake that they, besides these three, they write presbyopia also as a refractive error. But presbyopia actually is a age-related decrease in the knee accommodation, which causes decrease in the near vision after the age of 40. And we have to give reading glasses, and obviously they are of plus lenses. As the age progresses, the number increases, and it usually stops at the age of 60 with a maximum reading glasses of plus 3. And after 60, if the patient has not developed cataract, plus 3 will be sufficient for him after 60. Thank you very much. Any questions?